Okay, well, thank you very much. It's just about 2:15, and I'd like to get this session going as soon as we can. This is the LGBT Health Disparities session, and I'd like to just briefly introduce our three presenters. We have with us Bill Snook over there. He is the Program Manager for Health and Social Marketing at the City of Kansas City, Missouri Health Department. He was one of the project leads on the 2003 and 2006 Plus, which was one of the first comprehensive LGBT community health assessments ever done in the nation, and the first to be replicated. He also attended the American Legacy Foundation Priority Population on LGBT tobacco use, which was one of the first meetings of its kind. As a technical resource, he has assisted various statewide and national projects, and as a lifelong learner, his goal is not to get the right answer, but rather to ask better questions to get at better answers. And then next we have Sherrill Wayland, and she worked in the fields of disability advocacy and education for 12 years. In 2004, she became actively involved in the LGBT equality issues, including the 2004 Missouri Marriage Amendment, PROMO, and is the founding member and secretary of the Gateway Stonewall Democrats, which led her to her desire to use her professional skills, advocacy skills, within the LGBT community. Ms. Wayland returned to academia and received a Master of Social Work in 2008 from the George Warren Brown School of Social Work at Washington University in St. Louis. She used this time to research LGBT aging issues and start the St. Louis LGBT Aging Task Force. Upon graduation, Ms. Wayland became the founder and current executive director of SAGE Metro St. Louis, Services and Advocacy for LGBT Elders, GLBT Elders, and co-authored the article Older Gay, Lesbian, and Bisexual Adults, Tools for Age-Competent and Gay Affirmative Practice, which was published in the Journal of Gay and Lesbian Social Service. Okay, and Jane McElroy. Dr. McElroy is an assistant professor with a joint appointment at the University of Missouri's Family and Community Medicine Department and the Research Reactor. As an epidemiologist, she is interested in influencing diseases through exploring etiology, through biomarker analysis, and describing disparity health outcomes in the sexual and gender minority population. One of her projects, funded by the Missouri Foundation for Health, is to work on tobacco control with the sexual and gender minority populations. And that's the first time I've read that much out loud in one time. So we'd like to go ahead and get started with Bill.
Okay, good afternoon. How are you guys doing? Just to remember, I'm an old teacher. I'm here. I'm your presenter. Get used to it, all right? What we're going to do, just to start off this afternoon, I just want you to just do a repeat after me. If there's no box to check, you don't count, you don't know. That's going to be the theme of what you're going to be talking about in LGBT health. LGBT health is relatively a new kid on the block. We've been around since 1975. However, we're just kind of sporadic. And now there's really big momentum going forward. Yeah. So this is what we're going to do. And just to let you know, this is a 60-minute presentation that we're going to do in 20 minutes. So I've had caffeine. I hope you've been having caffeine. It's going to be a great day. We're going to talk about what is LGBTIQ, orientation and gender identity. There's other things that we could talk about, but we're going to just kind of simplify it. The 2003 and 2006 Pulse, the Kansas City TGA HIV risk, Institutes of the IOM report, HHS Actions, Joint Commission, SAMHSA, Gay and Lesbian Medical Association, and considerations, whether it be community and culture. Okay, lesbian is easy. Gay is easy. Bisexual, hard to get. Transgendered, intersexed, Q. With Q, we have the LGBTIQ. Usually you'll see LGBT. In 2003 and 2006, we only used LGBT. We didn't use I, and we didn't use Q. Q can either be queer or questioning. Just depends. It could be on the coasts. It's more acknowledged. In academic situations, it's more acknowledged. In more progressive situations, it's more acknowledged. There's a lot of folks that really don't like that word, but it's beginning to change. So let's go with our definitions. Sexual orientation is generally defined as an individual's enduring physical, romantic, emotional, and/or spiritual attraction to another person. Gender identity is generally defined as an individual's internal personal sense of being a boy or girl, man or woman. For transsexual people, their birth assigned sex and their own internal sense of gender identity do not match. These are not the definitions. These are a conglomerate of definitions. Gender identity and sexual orientation are not the same. Transgender people may be heterosexual, lesbian, gay, or bisexual. There's a whole gamut. We're going to be talking about a lot of things that may be challenging. For some folks, your brain may be on fire right now. That's okay. It's all good. So what do we know of LGBT health, no Q or I, before the 2003 Pulse? Not a lot. We knew about HIV. Lesbians had breast cancer. Gay people smoke. And they commit suicide. Those are the areas that we knew. And we knew them in 5 areas: Los Angeles, San Francisco, New York, Chicago, and Minnesota. Don't know why. Maybe it was the winter. I don't know. So what do we know about the pulse of LGBT health in Kansas City? For the 2003, we had 1,143 participants. We're just going to go quick because this really is not the main focus, because this is like training wheels. We went to the community and we said, hey, we don't know a lot about you guys. What would you like to know? The community designed this survey. So we actually got some really good results. We could not publish because we could not use gay, lesbian, bisexual, transgendered. You could not use those terms in 2000 in research. Okay, and all the research in the room is going, what? Remember, conservative agency, NIH. They get funding. It becomes political. When it becomes political and money's involved, you're going to use the term men who have sex with men, women who have sex with women, because it'll be about the behavior, not the orientation or their self-identified feeling. So this is just some of the sample data that we had. White lesbian respondents out to their healthcare providers. Uh-oh. There's a lot of none going on. There's a lot of all. There's a lot of some, but just take a look. Remember, if there's no box to check, you don't count. You don't know. Okay? So we had the younger folks, they weren't out. Body dysmorphia in gay men. Granted, we use BMI. I'm an exercise physiologist. I hate BMI. It's evil. It should be for populations, not for people. Sorry, disclaimer. But if you look, they self-class themselves as underweight, but they're normal or overweight. That's a bigorexia issue. Self-class, overweight or obese, they're underweight. So you're probably looking at saying, well, those image-conscious gays. You do this study right now with heterosexual men, you'll find the same thing now. Domestic violence in prior 3 years. Remember, these are what the community wanted to know. So we're seeing a large percentage of domestic violence that may or may not have been reported. Compared to the 2003 pulse, there was no change in the prevalence of respondents who may have had a body dysmorphic view or a reported partner sexual violence issue. I'm sure we all know we have to talk about HIV because we're talking about gay men. Just to let you know what we found, no relationship between frequency of testing and the number of sex partners. 30-plus partners here, never been tested. 5 to 6 partners, never been tested. We make a lot of assumptions that the younger generation knows. They don't. They take a pill, they go out to the bar, and they start tweaking out, and it's fine. Or now, they just use the internet. Why go out when you can order in? I bring this slide. Dr. McElroy is going to do a lot more with the Check It Out project. But I put this here because, as we heard from the last presentation, when you have small numbers, you really can't generalize, right? Well, in Kansas City, we make sure that we protect the confidentiality of the people who respond. LGBT communities can be very, very small. Everybody has, it's like Kevin Bacon. 3 degrees of Kevin Bacon. We could not release any of the transgendered information. In 2003, I was told by CDC we had the most complete picture of trans individuals in a community, but we could never release the data because there were 12. Okay? There's a lot more in the community, but there was a fear of being identified. Epidemics are local. This is just the HIV surveillance. White females, non-white females, non-white males, and white males. Just kind of show you the peak, and then where we are today. Just so you know, heart therapy started hitting right about here. That's when everybody started getting the highly antiretroviral therapies to prolong their life. So we saw a great reduction in the number of deaths. But if you look at the risk factor, remember, we have to use MSM because we're looking at behavior. That's MSM, intravenous drug user, MSM, it's still there. In Kansas City, it's predominantly men who have sex with men that's transmitting HIV. Well, we'll get to questions at the end. So that's what we knew in 2003, 2006. In 2011, change occurs. We have the IOM report. This is landmark because it was a non-political affiliation saying, look at all the data and let's see what we come up with. So this was the committee's charge. Conduct a review of the state of science on LGBT health, identify research gaps and opportunities, outline a research agenda, discuss research methods, and consider research training needs to foster the advancement and knowledge about LGBT health. Okay, this is March in 2011. What they found was research had been conducted unevenly, with more research on gay men and lesbians and less on bisexual and transgender individuals. Most research had focus on adults, with less on adolescents and few on LGBT elders, which Sherrill's going to talk about. Research had not adequately examined subpopulation, particularly racial and ethnic groups. Here's another thing that I would have thrown on this. There's also cultural community groups within the community. So I would have said racial, ethnic, and social community groups, because sometimes they don't meet the other folks. So now we have the HHS strategy to improve the health and well-being of LGBT communities. Landmark, when you guys get this online, You can go to the links. And now we have the Joint Commission, Advancing Effective Cultural Communication, Cultural Competency, and Patient and Family-Centered Care for the Lesbian, Gay, Bisexual, and Transgender Community, a Field Guide. That's what for accreditation for hospitals. They're now saying your LGBT patients are valued. Because remember, no box, no check, no count, don't care. And then this actually was just released. The Top Health Issues for LGBT Populations Information and Resource Kit. It just came out from SAMHSA. I think it was in February. So I'm just going to flick through these slides. These have not been updated from GLAMA, the Gay and Lesbian Medical Association, which was the premier LGBT health care, healthcare, not public health, that we had for a long time. So remember, with lesbians, breast cancer, depression, heart health, gay men, HIV, AIDS, substance abuse, depression, anxiety, transgender, access to healthcare, health history, and hormones. So now we have new developments in 2012. HRSA now supports LGBT community health centers. Remember, 2003, we couldn't even publish anything that said gay. SAMHSA, reviewing all funding announcements for LGBT inclusion. It will affect the state block grants. They haven't figured that out, but it will. Chicago has just created an LGBT health action plan. That was just released about a month ago. Missouri will now start collecting LGBT health information on the quit line. Hospitals undergoing Joint Commission accreditation require a non-discrimination clause that includes sexual orientation and gender identity. And then we have HHS Office of Civil Rights is taking and investigating complaints with hospitals. And it could affect their federal reimbursements. That's big. But with all of this, 2003, not a lot of information. And we have been on warp speed, going very fast, trying to get information out. But remember, this is a political system. Next, Congress, next, Senate, next, President is going to set the tone. All of this can change. Okay? Considerations for LGBT IQ. We need to talk about community. Is it closed? Is it open? Is it internet? What are the access points? Geography and region. And sometimes the community is very mistrustful or very cautious about people wanting to know more about them. With closed, there are some communities you just can't get into unless you're part of it. They will block you. Some of them are very open. And some communities are all online. Access points. We were not San Francisco in 2003. I was not Minnesota in 2003. Does it look the same? Does it look different? I don't know. We don't have any comparable data because there's not a lot out there. Culture, just a peculiarity with the community. Open relationships, closed relationships, partnerships, families. There are subgroups. You have leather, bears, houses, balls, sports, femmes, butch. It goes all over the place. There's a lot of history. You have the Holocaust with the pink triangle. You have the Mattachine Society in 1951. You have Stonewall in 1969 because gay men could not congregate and be served alcohol. If there were 3 and more, there could not be any alcohol because it would contribute to their deviancy. And then we had the raids. 1973 and 1975, Diagnostic and Statistical Manual of Mental Disorders. You could be institutionalized if you came out as gay. You could be lobotomized. You could be castrated. Those are real stories. That's only from 1975. The hepatitis vaccine trial in San Francisco, some of the older generation of gay men who were in San Francisco at the time, in 1978, CDC came in and said, hey guys, there's this new hepatitis B vaccine. Come get your vaccination. It was pulled by 31 donors, the blood was. It may have been contaminated. All the people who received the vaccinations are now no longer there. They're no longer alive. It's a theory. It's part of the lore. It's part of the culture in some of the community. Do we know if it's right or wrong? No. But remember, perception is 9/10 of the law. It doesn't have to be true. And then we have A's and Matthew Shepard. Then there's also the race and ethnicity lens. Just being LGBT doesn't mean you're just LGBT. I'm coming out now. I'm an immigrant. I'm from Canada. I was born to American parents. I'm a dual citizen. I have 2 birth certificates. You know, I kind of want to be over there. But I'm talking about gay stuff. Those are the other things you don't know. Remember, if there's no box to check, you don't count, and you won't know. There are some health resources. If there is one place I can direct you to for LGBT health, it's the Network for LGBT Health Equity. You have all these other folks here, and we have SAGE, and we have Out and Proud and Healthy. If you want to know what's going on a national level, the Network for LGBT Health Equity has been invaluable. They are the ones that are going to rabble-rouse, have those conversations, and fight for you, fight for LGBT folk. But with that, thank you for letting me count, and I'm going to pass it off to one of my colleagues.
I think I neglected to say that we're going to hold all of the questions to the end of the 3 presentations, and I think I also neglected to introduce myself. I'm Amy Lake with the Center for Health Policy. So with that, here we go.
Do you have a bio for us?
Oh my gosh. Maybe another day.
Thank you, Amy. Get this back in. Thank you, Bill, for the wonderful intro into our panel today. I just want to thank everybody for being here. I know it's late on a Friday afternoon. Would rather be on the road back to Kansas City or Springfield or St. Louis, right? But you're here. So thank you very much. It's an honor to be here and to present this information. When I was in graduate school in 2006, I was doing a lot of my research on LGBT aging. And I was just sharing before this panel started that whenever I would go to write a research paper, it seemed like the first sentence was always the same. Due to a dearth of information. There was nothing. There was hardly anything that we could report on. And when we did find research, it was typically based on studies of 200, 300 in small communities or in Chicago and San Francisco and Seattle, Washington, and Minnesota. What did that say about Missouri? It really didn't say anything. So we had to guess a lot of the time. What do we know? Well, we know what they know out in California, but how does that really relate back to St. Louis, to Columbia, Missouri, to Springfield? So it was really hard, to formulate research questions and really think about the work that lay ahead of us. But from 2006 to 2011, things have changed drastically. And this research that I'm going to share with you today is part of that change. This was actually done by our lead researcher, Karen Fredrickson Goldson, who's out of the state of Washington. And this study was funded by the National Institutes of Health and the National Institutes of Aging. And it's the largest, first ever national study on LGBT aging across the United States. So I'm very honored to get to present this information with you today. Sage Metro St. Louis actually took part in helping to get the survey out to our communities, and we actually did have people across the state of Missouri who took part in this data that you're going to be seeing today. So making it possible. This was a project that had support from 11 different organizations, community-based organizations across the United States. And it was really our job to reach out because we were the people in the communities. We were the ones that had those connections with our older adults and had built that trust. So when they received an email from me versus a university in Washington, it made a big difference. Oh, this is from Sherrill at Sage. I think I should take a look at this. And people would actually then go on and complete this survey, which I don't think would have happened without that community engagement. The report sponsors are the National Gay and Lesbian Task Force, the AARP, the Gerontological Society of America, and Gero Ed Center. So closing the gap. When the researchers first started looking at this, they used data from the Behavioral Risk Factor Surveillance System. Is anybody familiar with that study? It's out of the state of Washington. And it was one of the first studies that actually asked the questions about sexual orientation and gender identity. And so they used that kind of baseline data to then develop the national survey. But what they found through the data out of Washington was that 2% of people 50 and older would self-identify as LGB or T. And we know from many of our researchers that there's been a hesitancy to ask about sexual orientation and gender identity. One, we sure would hate to offend somebody who doesn't appreciate being asked about their sexual orientation or gender identity, so we're just not going to ask about it. And then second, people aren't going to tell us, so why are we asking about it? Well, this research showed that, yes, people will self-identify. And the information that we gain when people self-identify is very important as we start to look at the health disparities that impact our communities. We had 2,560 LGBT older adults who completed this survey across the U.S., and their ages range from 50 to 95. And what we found was that there are higher rates of disability, there's more mental distress, and that LGBT older adults are more likely to live alone. And those living alone are at serious risk of social isolation, which is linked to poor health and oftentimes premature death. Now, that's not the first time we've heard this today, right? That living alone can oftentimes lead to premature death. That's something that we're concerned about as we start to look at our LGBT communities. I need to catch up with my handouts here. We know that the health disparities exist based on sexual orientation and age. I think one of the things that's different when we talk about the LGBT community is that we oftentimes tend to lump everyone into the same category, LGBT health disparities. But there are distinct health disparities among lesbian women and bisexual women, among gay and bisexual men, and among transgender men and women. There are distinct health disparities. And we continue to do an injustice if we only look at it as an umbrella and don't start to really dig deeper and see what's going on with each one of those distinct categories. one of the older men that they interviewed for this study, he was 66, and this was one of his comments. As a 66-year-old participant, isolation, finding friend support, caregiving, and health issues are the biggest issues older gay persons face. Who will be there for us? Who will help us without judgment? Who will help us without judgment? I don't want to get political, but I need to talk about something that's happening here in the state of Missouri right now. We have a state house who last week introduced a bill. And some of you are kind of shaking your heads. Who knows what I'm talking about? There's a group of state legislators that want to ban all talks of sexual orientation in our public school systems. In other words, you can't say gay. Now, if we can't talk about sexual orientation, if we can't talk about safer sex for all students, if we can't allow that child who's struggling with their sexual orientation or their gender identity, then we are failing our children. We have to be able to talk about these issues. Our youth, our middle-aged, and our older adults, they want to know that they can receive quality health services, quality educational services without judgment. When we're judged, it leads to poor outcomes, right? And that's why we're here today. That's the last political statement. So what are some of the risks? Again, we found distinct differences among our LGBT older adults and groups. For example, lesbians and bisexual older women report heightened risk of cardiovascular disease and obesity more than their heterosexual counterparts. And gay and bisexual older men are more likely to have poor physical health than their heterosexual counterparts. And this is oftentimes linked to HIV disease. This is alarming because by the year 2015, it is likely that more than half of the 1.1 million Americans living with HIV will be 50 years of age or older. We're seeing for the first time people actively aging with HIV. We're seeing a rise in new HIV cases for people that are 50 years of age or older. These are things we don't talk about within our communities. These are things that people still feel uncomfortable with, but we have to start talking about them. I go into nursing homes and I go into hospice providers and to assisted living communities, and we're talking about safer sex with older adults because our older adults are at risk for HIV and aging. How many of you have parents? How many of your parents are, I don't know, maybe single right now, dating? Some of us have older parents who are single, right? We need to start having these discussions with our folks, with our parents, with our aunts and uncles, because many of our older adults never heard the safer sex messages, and so they are at risk. We also know that there's higher risks of smoking and acute drinking within the LGBT community. And LGBT is often used in research and services, yet they are distinct groups with distinct needs and specific needs that must be addressed. Adversity. We've heard about this too, that a lot of times where there's communities with violence, that we have poor health outcomes, right? This survey found that 82% of the people surveyed had been victimized at least once. And when we asked this question on LGBT research, the way we word it is something like this. Because of your sexual orientation or gender identity, have you experienced violence? And then they may ask what types of violence. So this is based on a person's sexual orientation or gender identity, okay? 82% have been victimized at least once. 64% have been victimized 3 or 4 times. 21% did not receive a job promotion based on their sexual orientation or gender identity. And we know that many within our community have actually been fired simply based on their sexual orientation or gender identity. In the state of Missouri, it is still legal to fire someone based on their sexual orientation or gender identity. And most of us don't realize that. But when this is what you're living with on a daily basis, it creates a great deal of anxiety and emotional stress for an individual and for a community. Victimization and discrimination are linked with poor outcomes within the LGBT communities. We had a 95-year-old man was asked, when did you first know that you were gay? And for this survey, he stated, when I was 15. And they said, when did you first tell someone that you were gay? And he responded, when I was 90. So for almost his entire adult life, he lived closeted. He more than likely never shared that information with a healthcare provider, with a social service organization, maybe not even his friends or his family. He kept all of that information internalized for his entire life until the age of 90. We had a 56-year-old transgender woman who shared, I have had an overwhelmingly positive experience with my gender transition so far. But I would say that my primary concern about the future is with access to health care and potential discrimination as a senior, especially if the need arises for emergency or long-term care. I just recently heard a story about a transgender woman who had just moved into a nursing home, and she had not disclosed the fact that she was transgender because she was afraid. If I disclose, they might not let me live here. Then where do I go? What do I do? So she didn't disclose. And oftentimes our older transgender community, because of pre-existing health conditions, can't afford to completely transition. And when I say that, they can't afford surgery. Okay? So an LPN went into her room that next morning to help her get up and get dressed and take a bath and discovered that she had a penis. You know what the LPN did? Ran out of the room screaming. Definitely not a good outcome for the new resident. And I'm going to say it wasn't a good outcome for the LPN either. So we have to be much more honest in our healthcare settings and our long-term care settings and start talking about the issues impacting the LGBT community so that we can support everyone in being culturally competent and being able to provide care with dignity and respect. We also find that there's a great deal of resilience within our LGBT older adult community. And why wouldn't there be? They've had a history of facing victimization and oftentimes discrimination and harassment and violence and hatred on a daily basis. So the skin starts to get pretty tough. And that resilience it's a positive thing for our community. We find that 91% participate in wellness activities, 82% engage in moderate physical activities, and 38% practice spiritual or religious activities. And I think the alarming statistic that most people don't recognize is military service. 41% of transgender older adults, 41% of bisexual men, 31% of gay men and 7% of lesbian and bisexual women had actually served in the U.S. military. This is something we need to be proud of within the LGBT community. Even at the risk of being discharged, they were there serving this country to protect us and so that we could all enjoy the freedoms that we have. A lack of access. 13% were denied or received inferior health care. 21% did not disclose their sexual orientation or gender identity. Bisexual older adults were even less likely to disclose their sexual orientation or gender identity. And the American Medical Association warns physicians that a failure to recognize and patients' reluctance to disclose can lead to failure to diagnose serious medical problems. We also find that there's unique supports within the LGBT community. Many of us don't have children. And who's the number one provider of care for older adults? It's children. But we oftentimes find that we develop our own family structures. We have our kinship groups, those close friends that we know will be there no matter what. But oftentimes they're the same age as us. So where does that lead us? A bunch of 80-year-old lesbians running around trying to take care of each other, right? Or 80-year-old gay men. But, this is another challenge that we have to look at. 30% have no will. 36% have no durable power of attorney. If they don't have a durable power of attorney, even those 10 friends can't be there to help make the critical medical decisions that need to be made. There may be limits in the friends' and ability to provide care over the long term, especially if decision-making is required. And I am getting up close to my 1-minute mark, so we're going to try to wrap it up. Some of the needs that this survey found were needs for senior housing and transportation, legal services, social events, and support groups. Pretty much everything that we've talked about today. These are the needs of the LGBT community. Most services fail to take into account the unique needs facing LGBT older adults and their caregivers. And if we're failing to take these things into account, then we're failing a segment of our communities. Moving forward, we need policies that are responsive. We need services that are responsive, and we need more research. There are many researchers in this room today, and I can guarantee you that there are groups here in Missouri that will work with you to make sure that the research is being done. The Older Americans Act. We need the Older Americans Act to really address some of the critical issues around aging. And we need prevention and interventions tailored to the unique needs of the LGBT community. LGBT older adults represent the past and the future. We can only end health disparities within the LGBT community if we start addressing them today. So even though I work for an organization that serves elders, it's just as much about our future elders as it is our present elders. And my hope is that 20 years from now, every one of your organizations represented here today will be partners in this work in Missouri. That's really what we do, is we build partnerships, we collaborate, and we invite any of you to be partners in that work. Thank you.
Okay, last, hopefully not least. It will definitely not be least when we look at numbers and data, because that's what I do. I'm very much interested in looking at numbers and seeing what we know about the community. We've been working, we metamorphized the project from, it was originally called Checkout, and now we're called Out, Proud, and Healthy, to kind of think about where we want to go with the community and what we want to be thinking about out, proud, and healthy. That's kind of where our vision is about this work what we're doing in this community. Kevin Everett and myself are the two that have been doing a lot of the work at the University of Missouri, and we've been funded since 2008 for this work with the Missouri Foundation for Health. So we really appreciate that funding and appreciate the vision from the Missouri Foundation for Health for stepping up to the plate and saying we want to find out more about the community and find out what's happening. So we know a bunch now. So you've heard. So the first thing I guess I wanted to say, I was like, wow. Okay, sorry. This is Missouri, right? Missouri, and what did I hear? We were the first state that had comprehensive data. That was from Bill. And then Sherrill got up and said we were the first state that was able to address issues with the elderly in this community. And now I can say we're the state for numbers of data for this community. Missouri, really? All right. I like it, but Missouri? That's amazing. I'm really quite impressed by that. Okay, so just briefly, this project was 3 phases. It started with an assessment phase, so we wanted to find out what was going on in the community and do surveys and talk to people and do focus groups and figure out what do we know, what do we want to know, basically building on what Bill has done with the Pulse project. So we built on that in the assessment phase. Then we moved into doing a planning phase, which was a 8-month project, and all we wanted to do was say, well, okay, we think we have a better understanding of the needs of the community. Now, what do we want to do towards tobacco control? And that was a planning phase, and now we're in the 3rd phase of it now, currently, and that's an implementation phase. We collected survey data at Pride festivals, and there are 5 big ones in Missouri: Kansas City, St. Louis, Black Pride Festival, also St. Louis, Columbia, and Springfield. Those are the 5 that I'm aware of that we go to, and we collect survey data there. We've done it in 2008, 2010, 2011. We will be going this year in a week or 2 and start our next phase in 2012. So it's cross-sectional data that we've been collecting. And what you'll see for the data that I'm going to show you is I'll either compare it to a comparable question that was asked of the population of Missouri, or if I don't have that, a national study. So you'll see the data that I'm trying to compare the community with mainstream community in either of Missouri or of the nation. And we have lots of numbers. So this is to give you a sense of, mostly I'm going to be talking about the 2011 data, okay? And those are the places and the locations. What we've also done to try to make the survey representative of the community is also do a internet-based, web-based survey to capture people who don't go to the Pride festivals but have a voice. So that we're trying to be a much more comprehensive representation of the community. So we're doing Pride surveys and the web for this, and there's the numbers. So we have adults, that's 18 and over. We have 3,275 survey responses that we'll be talking about. So we've got fab numbers, so we can look at by age groups, by races, by sexual orientation, identities. Just a couple general characteristics of the population. It's a young population, so Cherrill's done a lot more. She has a lot more information on an elderly population, an older population, and people who go to the Pride tend to be a bit younger. But we do have people in the older age groups, and our race reflects Missouri. In fact, we have a bit higher race percentage of people who are Black and self-identify in this group, in this community, than that's in the state. And our education is we're a bit more educated. So the sample is a bit more highly educated individuals. Here's our questions. Some people want to know, well, how did people do it? It's self-identification. And we asked them, do you consider, and then do you identify as transgender or transsexual? And note our numbers for transgender or transsexual. So Bill was talking about 12. We have 108 that have self-identified as either transgender or transsexual. So here's some statistics on some of the things we asked. So we were really interested in tobacco, so we asked quite a bit about tobacco. One thing that we were interested in is smoking status. And what we know, and we've done this now for a few years, is yes, this community smokes a lot more, and about 2 times the rate. Okay? And it's about the same for all the different subgroups. Right? So it ranges from 35 to 42% or 20. Right. Now, in the bottom line is the Missouri data. So it's Missouri data for just a general probabilistic-based data is 23% are smokers, are current smokers, whereas we are, in the high 30s to low 40s. Something that is also it's a hot topic right now in the smoking literature is this light smokers or occasional smokers. And that's a very hot topic these days in that world. And in this population, and I don't do the acronym stuff because there's so many alphabets that I kind of get lost. So I've moved, and this is what some of the national folks are moving towards identifying this community as sexual and gender minority, SGM. It's a lot faster than LGBTQI. So that's where you see the SGM here, okay? So the SGM population for light smokers is actually considerably more. So someday their occasional smokers is 5 times more likely to be someday smokers. Now, the Surgeon General's report came out and said if you smoke 1 cigarette, that's deadly. So it doesn't mean that the negative impact of health on smoking is less in the community. It just means that they're exposed a little bit less, or quite a bit less. The one thing that it's a little bit of a conundrum to us is that we tend to know in the tobacco world, if you're educated, you kind of go ding ding, smoking's not good for me, and if you are a smoker, you quit. And with this population, we're not seeing that. So this is the one that's sort of shocking, is that for the community that's college educated, we are actually seeing they're smoking 2.5 times more likely to smoke than the mainstream educated population. So the rates are 25% of college graduate SGMs smoke compared to the mainstream of about 10. And that's like that. We're not sure. That's shocking to me. Okay, let's look at alcohol consumption. And we know cigarette smoking and alcohol consumption go hand in hand. And so for the risky alcohol consumption, if you're looking at, these are for folks that are having, for men or for male to female trans, that's more than 2 drinks a day. And for women or female to male, it's more than 1 drink a day. Or binge drinking is at 4 or more drinks, or 3 or more drinks is the binge drinking category. We're seeing that for the SGM, it's about 50% are in this category, versus the Missouri population at 24%, 25%, so about twice as much. This is probably the one that's the most curious to me because it's counterintuitive from kind of things I've heard before. There's a standard question that's asked on a lot of surveys and just says, in general, how would you describe your health? And you get 5 choices, and you just check the one. And so what we found here is that in this community, the SGM are much more likely to report being in better health than the mainstream, which is kind of counterintuitive. I'm not sure exactly what that means, but we could discuss it. We asked just a question about your eating. How do you feel you eat? And it's slightly less likely to report healthy eating, but not as dramatic of a difference as smoking or alcohol. The lowest group of people who reported poor eating was transgendered, and the group that reported the best eating was bisexual male. We asked about depressive symptoms, and this one's not a surprise. So again, we're getting about 3 times as many of the SGM are likely to report depressive symptoms. Not a big surprise. Access to care. So this is in 2011. We just asked about health care. So we asked, and this is a bit of a standard question, are you currently covered by any type of health insurance or some other kind of health care plan? Okay, so we're just asking about access. And what we're seeing is more SGM do not have health insurance compared to the mainstream. And then the percentages are by group, and they more or less are the same percentages. How about medical care, medical treatment, or prescription drug use? Again, so in the last 12 months, this is about did you need medical care or surgery and didn't get it because you didn't get it? And we're seeing about double of the SGM are not getting what they say they want. And then we say, well, let's look at just the older, and we had much smaller numbers there. It's double. So of those who are 65 and older, it's about double who say, I needed health care, and I didn't get it. Okay? And then in the last 3 months, did you take less medicine than you should have because of cost? Again, for those who are 55 and older, it was about triple said, yeah, I didn't take what I should have taken. And then for those who are 65 and older, in 65 you think about Medicare, they're eligible for Medicare, so you're thinking, well, it should be okay then. It is pretty good. You know, the difference between 6 and 4% is probably not statistically significant. So once, at least for the medication, it looks like it's okay. For getting the treatment, it's still, if you're 65 and older, it's still not looking okay for some reason. Okay? So what did we find? That's a whole lot of numbers and a whole lot of stuff. So what did we find? Here's a summary. So the SGM community is about 2 times more likely to smoke. They're about 2 times more likely to be risky alcohol users, slightly less likely to eat as healthily. They're about 3 times more likely to report depressive symptoms, but overall, they say, the community self-report says, I'm in better health. They're about 1.5 times less likely to have health insurance, about 2 times more likely not to get medical and surgical treatment, and about 3 times more likely to take less medicine than they need to, except in that age group, that 65 and older. So that's a snapshot of where we're at in what we sort of know at this moment about the community from our surveys that we've done. I think we've said this over and over about different populations and the health disparities. Acknowledge again the Missouri Foundation for Health, and Dean Anderson is here, and Kimmy Onolte has helped us, and Jenna Jordan gave a poster that maybe some of you saw talking about looking at the African American SGM community, and Angela. And we had national consultants, Kitty Jerome and Dr. Scott. And we'd like to also acknowledge the people that were on our advisory board. And these folks came together and helped us out thinking about what to ask and how to think about things. And was very important to us in our projects. Thank you.
Okay, I'd like to thank our 3 speakers again, William Snook, Sherrill Wayland, and Jane McElroy. And we're going to go ahead and open it up to questions. Question over here, and if you could just state your name and then your question. And you guys have a mic up there.
I have a question, and I'm sorry, I've forgotten your name. I'm terrible with names. You mentioned that Sherrill. My name's Richard. You mentioned an issue that's very concerning to me about the gay-straight alliances. They're not going to be able to use that word in school. I'm very worried about that because gay students, as you know, need to be able to identify their allies. Has the governor weighed in on that issue? I would think he would be the way to stop that, given our state of our legislature.
I would actually like to throw this over to my esteemed colleague, A.J. Bockelman. A.J. is the executive director with PROMO, which is our statewide equality group, so he can better address the political aspects.
Thank you, Sherrill. Briefly, the bill's dead. It's not going to go anywhere. We've received the assurances from the committee chair where it was referred. The outcry on this has been tremendous. We're keeping up the effort, though, because they still are not addressing the issue of bullying in schools. So we'll likely have a press conference there next week, along with some gay-straight alliances. The governor is not likely to weigh in on it because the bill's just simply not really going to move.
Hey, okay, question in the back.
Hi, Leslie Porth with Missouri Hospital Association. My question is for Sherrill. And as you were talking about perhaps the older population, but maybe all populations of patients who are reluctant to self-identify, I wondered if there is some generic assessment questions that providers could ask every patient that would help them understand this may be somebody who's reluctant to self-identify, but is at risk for some of the health issues that you raised today.
I believe that the standards that JACO has put forth really starts to address this issue. And so I think the key now is that health professionals in the room pull that document off the internet and actually start looking at it and talking with your colleagues about how we can start to implement these changes within our healthcare settings. Yep. Thank you, Leslie.
My name is Ruth Ramsey from Kansas City, publisher of Our Health Matters magazine. I'm interested in knowing what tactic or strategy do you have for trying to get African American churches, faith-based organizations, to at least be an advocate for better health of those persons who do need care and to be embraced. It's certainly, as you know, something that they don't want to embrace, but I'm very concerned that people are people and people need health care, and everybody needs health care no matter who they may be. And so do you have something in your plan to help us and arm us, and even as a media, to be able to better speak to those issues for our community?
Real quick, there's at a national level, SAGE is part of a national group of affiliates, and there are over 20 SAGEs now across the United States. And at a national level, SAGE National actually convened a diverse elders coalition. And on that coalition is, an organization that represents the African American community, Native American community, the Asian community, people with disabilities. It just really goes on and on and on. And part of that coalition is to start doing, some of this very work that you're talking about. In St. Louis, what we're doing is trying to get more engaged with some of the health fairs that really target communities of color, so that we're also there and at the table and meeting community members, meeting church leaders. We basically will go anywhere that people ask us to go, but we also need to make those connections, with more of our faith-based communities. And I think Jane has something to say.
The other thing that I've noticed in reading research and looking at and talking to people about how can we have change happen, it seems like a critical component of change happening in an organization or an institution is change makers within the institution. So sometimes it's hard for outsiders to come in and say, "Oh, you guys should do X, Y, or Z." It's often very helpful for the change maker to be a champion within the organization. So with the tobacco work that we do, the best way to get an organization like a treatment center to go smoke-free and implement a policy is if there's someone within the institution that is there every day and wants to do that and they move it forward. Similarly, that also happens with change within churches. I think if it's church members and there's a champion within the church, I think it can happen. And so part of it may be just identifying those who may be interested in taking on that role.
Hi, everybody. Thank you for a wonderful presentation. I'm Ioana Steklesko. I work with the Center for Health Policy. And I think I have a question for all of you. Can you talk a little bit about your efforts in kind of reaching the healthcare provider community? Because we had a wonderful session in the School of Medicine, and someone talked about what the experiences they had with the healthcare system, and they went in for a pelvic pain, and then the provider told her that she didn't come out to her parents yet, so that must be the reason for you hear all these stories, and it's just so terrible, and you think, what can we do to, reach providers better, or maybe, even educate the public more about what's going on, but especially the provider, because you're going there and you trust the provider to take care of you, for your physical illness and everything. So thank you.
I'll quickly talk about it and then pass it off. Currently, there is a project happening in the state of Missouri called an LGBT Health Access Roundtable, and that's a partnership between SAGE and Promo, and it's being funded by the Missouri Foundation for Health. And part of this project is to bring some of our key stakeholders in health to the table to start addressing, some of the very issues that you brought up. Oftentimes, we ask our community members when they're looking for medical professionals to go to a website called the Gay and Lesbian Medical Association. For the whole state of Missouri, there are only 17 medical professionals listed that identify as either being LGBT medical professionals or allied. And so if that's the resource that we're really looking at to guide us and where we can find friendly and culturally competent care, then that's an issue.
And to piggyback on that, a lot of those providers do not want to be listed because they don't want to offend those who may not have the same worldview as them. So a lot of times you have to work through the community and find out who they go to. And they'll talk about who they've had good care with and who they've not had good care with. And unfortunately, it's still pretty underground right now.
So for the providers, at University of Missouri, what we're working on, I think a little bit more actively, or a lot more actively, is the students. So we're doing, with the medical school at University of Missouri, we have problem-based learning, and so we're going to be developing a case where the students have to go through a case, and one of the characteristics of the individual is the sexual and gender minority status. In the school itself, we have just right now, the students are going to be taking an exam, and they had to read a paper it was about tobacco use in Missouri, and they had to read the paper and discuss it within their small groups. So, and one of the things they had to do was the paper specified the categories, and Bill didn't speak about this, but one of the categories was genderqueer, another category was queer, and so what does that mean? Define these terms. Well, they don't know this yet, so you can't tell them, but their exam next week, they're going to have a question on the exam, and that validates that that's important to know. So we're trying to get kind of backdoor and not have a special session on this, but have it part of the curriculum, so it just becomes normal. This is just something we normally think about. So we're trying to do some work at the medical school level.
Can I just say that I missed the roundtable that was here recently, but I think there are a lot of physicians who would be allied physicians that don't know about that. The first time I've ever heard that.
Of the gay and lesbian medical?
Yeah. I think there's a lot of people who would be open ally care providers who don't know about that. So
and I think that's our challenge is the people in this room are probably more aware of those allied doctors than what many of us are. And so we are really looking for partners that, can reach out to us and say, Sherrill, did you know that Dr. So-and-so in Columbia has a large gay and lesbian, clientele? And, maybe you should reach out to them. That's what we need so we can help to start building these collaborative relationships. So thank you.
Yeah, hi, I have a quick question. Ben Harvey, I work at the Department of Health and Senior Services, and I think I've seen Bill before, talked to Jane, I actually think I've been on a call with Sherrill.
Yeah, you've seen me now.
But Sherrill, you spoke with something that is a big issue for state agencies, and in that we're really dependent on the legislators and who's in charge to kind of follow what they do and take our roles from them and our responsibilities from them. So what do you see, knowing that we live in a very conservative state and all the issues that come along with that, what do you see, or what do you all three perceive as the role of the state agencies, like the Department of Health and Senior Services? What do you perceive as their role in issues like this, sensitive issues that may not necessarily be easily discussed, I guess, and easily addressed?
First, when we talk about elders specifically, we already have legislation in place that's there to protect our elders, and that's the Missouri Elder Abuse and Neglect Laws. And when I read research and hear stories about what's happening to our older adults, that's abuse and neglect. And I think we have to start calling it what it is. And so that's one thing. And then I also think we have to really start looking at the national standards that are coming down and ensuring that our states are also looking at those and saying, how do we need to change our systems so that we can better serve all people?
And since I'm with the city government, and even though they believe that Kansas City is the maverick and the rebel out there, it was very difficult to do the 2003. The 2006 survey, we almost got blocked from even releasing, for even starting it. What I would also say is that with what's going on with SAMHSA, with the block grants, Missouri will be soon having a choice whether they want to participate in block grants. They have their own ideas, and Missouri is known for turning away federal dollars because they don't want to play. But I think you should be able to call them on it, because it's not advocacy by that point. It's not lobbying, because they've already done the deed. But I think it's also letting people know that there's opportunities out there that are coming down, and we are the show me state. We shouldn't be the happy to be last state. And I think that that's where the culture shift and the normative change needs to be. I had to come out to do the survey. And the only reason it even happened was because there were some problems in the community. I was a title holder at the time. I provided that information to the director. The director called me and a colleague who also happens to be LGBT, and he said, I hear there's a problem. And we said, yes, it's pretty big. And he said, fix it. Just don't get me in trouble. We did all of it low key. And it didn't, and the powers that be didn't know until it was released. And we already had 2 allies who were elected officials to smooth that transition. But we as government didn't do it. It's we the people. So,
and I would also say that a lot of what we've seen come down out of the federal government, JCO standards, which that's not federal government, but the Department of Health and Human Services and some of the other organizations, they aren't necessarily passing legislation. They are changing policy internally within those administrative offices. And so I think in a state like Missouri, anytime we can look at policy changes that can be made inside agencies and try to do that, without really calling attention to the fact that we're saying gay, in the Department of Health and Human Services, but we're doing things that really start to protect people, then I think that's a bonus.
We need to kind of wrap up the session, but I can't leave here without owning up to what happened with this meeting. When our next grant cycle of the MOHEC came around, I won't say who, but a very high-level person in the state came to me, and last year we looked at African American and Hispanic Latino issues in this whole Missouri Health Equity Collaborative project. And I said, this year we're going to expand that to newcomers and refugees, and we're going to expand that to mental health and little substance abuse, and we're going to expand that to LGBT. And he said, you can't do that. And I said, well, yes, I can. And he said, no, you can't. And a conversation ensued. So I think it's just, we all have to just sort of say, yes, we can. We can talk about this. This is important. These people in our society matter. What?
She's a champion.
I would argue that we have both an ethical and a moral responsibility to do that.
Of course we do. Okay. I know it's the end of Friday afternoon. I know it is. But Tracy Branch is here, and she's the federal, this area. She's going to just say a few words before we all break. I know this is hard, but can we all go over there just for a few minutes? Okay, just for a few minutes, and then we'll let y'all go. Thank you. Let's give these guys a round of applause.